Okay. Good afternoon, all the audience. My name is Dr. Chatchada mahaweerawat from the Konkan University. Today, I will present the management of ACL injury in children and adolescents. The outline is term and definition. Why are adolescent ACL different between adult ACL? And treatment option and its complication. Graft option and to prevent the recurrent injury. First, term and definition. We should know what that means, the chronological age. The chronological age is a number of years that person has lived or age from the calendar. The second word is bone age. Bone age or skeletal age. Bone age is a degree of the person's skeletal development or defined as a skeletal maturity. It can be the same with the chronological age. And the last thing, the adolescent. Adolescent is a transitional phase of growth and development between childhood and adulthood. As you can see, this phase had development from state 1 to state 5. And this is my adolescent will look like this. Okay. Why is adolescent ACL different between adult ACL? The first key is incident. The incident, when we compare with the adult ACL, is more higher than adult, more 2 to 3 times. When we focus on the boy, high rate in the boy is 17 years old or to 18 years old boy. And the high rate in girl is 15 year old to 16 year old. But lucky, the important, most of kids are turning state 5, as you can see. Okay, and soccer is the most common sport associated with anterior cruciate injury. It's number 1. Okay, the second key why is adolescent ACL different between the adult ACL? Okay, because the high coincidence with the medical injury. From the descriptive, from the study, a prospective multi-center Pluto study showed the high rate of the medical injury. The medial medical tear is major, is up to 90%, but the lateral medical tear is around 66%. And in the tibial imminent fracture, it has a meniscus injury also. And mainly is lateral meniscus is up to 90%. And you need to examine the patient with the ACL injury had a meniscus injury too. Okay, the third point, the knee is developing to the maturity. What happened when the facet was violated? If you plan to do the anterior cruciate reconstruction in young patient, you're gonna deal with the open facets and small the femoral node side. If you do, you can destroy or violate the facets and can lead to the LLD or angular deformity. And if you start with the ligament reconstruction, I think everybody not want to end up patient with a colic deformity like this. Okay. The important thing, we should to evaluate maturation of the knee or the skeletal age of the patient. We can tell by history and physical examination or the radiology. By history or physical examination, we can use the chronological age, growth chart, terminal state. And in the radiology, we can use the film left hand PA or use the MRI knee to determine the patient's skeletal age too. The important side is fascial close in the index distal phalanx. That means fascial in the knee is close to and allow you to do the ACL reconstruction through the facet, or like the adult ACL reconstruction. Another bone age can determine by the MRI. You can see the audio sign here. The third line and the fourth line, you can see the aureole site is disappear. That means the facet is completely growth. Okay, for the clinical evaluation, an ACL injury is always non-contact injury and almost always dynamic wall gut injury. The history is acute onset audio pop on the knee and rapid swelling on the knee. Okay. For the physical examination, you can see the effusion or atrophy of the quadriceps. Clinical test for the ACL, you can test the ACL drawer test, Lomman test, and private cascading. Other examination is limb length alignment, Turner staging, and another association is you can determine too. Other risk factors just like the Q angle, tibial slope, malalignment, and dynamic walkout pattern you need to address too before you need to treat the patient. For investigation, you have to X-ray to rule out the osteochondral fracture, bony avulsion, tibial spine fracture, or and acetophysis. And you have to got an MRI and film left hand AP to determine the patient's skeletal age. The MRI show high sense and spec and can address the interarticular pathology or co-injury too, and can show the facet patency and facet projection that we can project the drill another tunnel. Okay, for the treatment, first thing first, for the tibial spine fracture in adolescent, if you do the MRI, you use the MRI classification. We have a 3 grade. First grade is non-displaced. Non-displaced you can treat by conservative treat or anything because non-displaced is always non-displaced. Okay, the grade 2 is posterior hinge. You can try the reduction inter-operative or knee arthrogenesis before the reduction, and you can do reduction and maintain the fracture site in the full extension knee. Okay, but the grade 3, the grade 3 of the tibial spine fracture, the important thing, you had a soft tissue interposed in the fracture site. The most common interposed soft tissue is intermeniscal ligament that you can to evaluate and remove before to reduction and fixation. Okay, but for the fixation, you can use the screw or the suture for the fixation. In the biomechanics study, the screw show lower load to failure than the screw or anchor, but show no difference between in a displacement. Okay, next thing is a mid-substance tear of the ACL. You have to decision making the treatment option and timing. Do you want to operate the patient, operate acute or delay? How many growth remaining of the knee? More than 2 years or less than 2 years? If operate, what the surgical technique and graft is proper? Okay, you need to ask yourself and the risk and benefit of ACL reconstruction. If you do ACL reconstruction, you have a risk of growth disturbance, revision surgery due to a small gap size. But if you not surgery, you will have a growth with instability and repairable meniscus too. Okay. The systematic review and meta-analysis show flavor acute anterior cruciate reconstruction when meniscus repair to reduce the risk of meniscus tear or a repairable meniscus tear too. Okay, this is a treatment algorithm. If the patient not mature or very young adult, you cannot drill through the facet. Okay, you cannot you use the transfacial. You use the facial sparing technique in the Turner state 1 or 2, and you can do the facet if the patient is more maturity. If the MRI, Okay, the first group is the patient is very young, the age is lower than 8 to 10 years old. We recommend to do a facial sparing technique. As you can see, left hand AP, you can see the appearance of the sesamoid bone or the hook of the hamate. For the Turner state, you can see the Turner state 1 or state 2. I recommend you to do a facial sparing. For the facial sparing technique, we have 2 techniques. The first technique is a facial sparing technique, Michel Coker. The result quite good, but they found the lateral thigh asymmetry around 48%, and graft rupture rate is up to 66%. This is lateral thigh asymmetry from harvest the iliotibial band. Another technique is over the top. Over the top has a good result. No of the patient has experience of the gap failure, but 6% have a minor limb length discrepancy and axis deviation in the X-ray at the follow-up. Okay, the second group, the facet is continue to fusion, but it's not filled. You cannot violate the facet. You only do the all EP facet. Oh, sorry. The patient is 14 to 13-year-old. The index finger, you can see the facet is not filled. The treatment option, okay. The turner state is 2 to 3. The treatment option is all EP facet technique. Or time facial techniques. Okay. The last group, if the facial fusion at the distal phalanx, you can see the fusion of the distal phalanx. You can do the facial respecting transfacial or traditional transfacial ACL reconstruction like in the adult too. Okay, how to avoid the facial arrest? We have a study the volumetric injury more than 7% has been shown a high risk of the partial facial closure in animal model. Okay, and how to reduce the percentage of the facial violation? We can place the deal in the medial portion away from the medial edge of the patella here. And the deal hole can still be, so sorry. And if you put more vertical, the femoral tunnel, if you do the tibial technique, can be decreased the percentage of the violet to the facet, as you can see the white line. If you use the anteromedial portal during, you can more violate the facet in the femoral condyle. And if you put a more vertical in the tibial footprint, you can decrease the percent of the violet of the facet. You can see in the graph here, variation of graph diameter from 6 to 11 diameter will increase volume percent removed from 2.3% to 7.8%, and increase the tunnel deal angle from 45 degrees to 70 degrees will decrease volume percentage removed from 4.1% to 3.1% as graph I show. Okay, the last is a systematic review the result of the all EP facet technique anterior cruciate reconstruction compared with the trans epiphyseal technique. The systemic review show no significant difference between all EP facet and transfacial. But a greater rate of patients unable to return to sport in transfacial in trans-epiphyseal technique, and trans-epiphyseal technique had longer time to return to sport too. Okay, for the graft option, we don't recommend the allograft or no allograft. The graft option is hamstring, iliotibial band, or quadriceps tendon graft. Quadriceps tendon graft are reliable graft sought in pediatric ACL if we need to precise the size of the graft. In sagittal MRI, quadriceps tendon thickness will show the adequate graft size after preparation to the ACL anterior cruciate reconstruction. For bone tendon reconstruction is not recommended. They cause a premature facial arrest with bone plaque healing around the facet. Okay, you can evaluation the semi-tenuous graft size by the cross-sectional area more than 16 square millimeter in the ultrasound at the knee joint level. This is my study. Okay, for the ACL repair, you need to make the perfect criteria for the repair too. To prevent the injury, you need to post-op rehabilitation program. You need to follow up LLD and angulation deformity until the facial was closed, and you need to have an ACL prevention program too. Okay. For the conclusion, if patient Turner stage 1 or 2, please no hold, no drill. If stage 2 to 3, no Alila, please take the side hold. If Turner stage 3 to 4, please respecting the hold. If Turner stage 4 to 5, you can do the traditional hold. Okay, thank you very much.